Good afternoon and welcome to Infectious Disease Grand Rounds. There is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interests have been mitigated. If you have a question for the presenters, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section and we'll be sure to ask for you. Also, a link to the survey evaluation will be shared at the end of the program. It is my pleasure to now introduce our first guest speaker today, Dr. Norman McCulloch, Jr. He serves as Medical Director of the Hyperbaric Medicine and Wound Management here at Northeast Georgia Health System.
Well, good afternoon. Thank you for attending, and thank you, Jennifer, for that introduction. Thank you for being here today, and today I'll focus on a critical and often underappreciated driver of limb loss in our diabetic population, and that's infections, specifically diabetic foot infections as well as diabetic osteomyelitis. The central thesis is simple. Amputations are not isolated events. They are the downstream consequences of either delayed treatment in infection or uncontrolled treatment of infection. Some housekeeping, no relevant financial relationships to disclose. AI was used in the creation of graphics only and reviewed personally for accuracy and relevance. By the end of this presentation, you should be able to define diabetic foot infection and diabetic foot osteomyelitis, understand and explain the progression of infection and how that leads to amputation, identify time-sensitive failure points, as well as identify any opportunities for multidisciplinary limb preservation. Amputations have a devastating effect on overall quality of life, reducing mobility, independence, and psychological well-being. The survival rates for those who undergo amputations are worse than for some types of cancers, highlighting the severe health consequences. And beyond the medical costs, the amputations also create significant personal cost and financial burden, not only for the patients, but their families. Each year, a staggering 154,000 Americans will lose their legs due to amputations, with the majority being due to complications from diabetes. Every 3 minutes and 30 seconds in the United States, a limb is amputated due to diabetes. Diabetic foot infection is the leading cause of diabetes-related hospitalization, and most amputations are preceded by diabetic foot ulcer and subsequent infection. What's often missed is that once a patient reaches amputation, we're no longer in a preventative phase, we're in salvage failure. And importantly, mortality after a major amputation rivals many cancers. So this is just not a limb issue, this is a survival issue. About 38 million Americans have diabetes, and by 2040, it's projected that roughly 10% of the world's population will have diabetes. Up to 25% of patients with diabetes will develop a diabetic foot ulcer, and approximately 50 to 60% of those with ulcers become infected. 20% of moderate to severe infections, lead to lower extremity amputations, and approximately 70% of all non-traumatic lower extremity amputations in diabetics are preceded by a diabetic foot ulcer. The 5-year mortality rate for those who undergo an amputation is approximately 70%. We took a look at some of the data in calendar year 2025. 416 amputations were performed across all levels. 66% were contained to the level of the foot and considered minor. 34% were either at the transfemoral or transtibial location, BKA and AKA, which is clinically and financially significant. Major amputations remain substantial, with 37% happening at the AKA level. And nearly 70% of major amputations involve diabetes, reinforcing the need for earlier intervention. Our biggest opportunities here are ER-based diabetic foot pathways, early vascular and podiatry co-management, as well as standardized triggers after a first foot level amputation. This is the cascade that we see repeatedly. Neuropathy leads to ulcerations, ulcers become infected, infection spreads deeper to the bone, and ultimately results in necrosis and amputation. The key point here is that infection is the pivot point. This is where we still have an opportunity to change trajectory. This is a perfect storm. Neuropathy leads to loss of protective sensation. Hyperglycemia impairs the immune response, as well as peripheral arterial disease limits tissue perfusion. When infection enters this environment, it progresses very rapidly, and critically, infection plus ischemia doesn't just add to the risk, it actually multiplies it. So what is a diabetic foot infection? DFI, as you'll hear me refer to it, remains a clinical diagnosis. Erythema, warmth, swelling, pain or tenderness, or purulent drainage. We often over-rely on labs and imaging studies to diagnose this, but the diagnosis is made at the bedside clinically. If you see two or more of these signs, it's infection. The real question is, at that time, the severity, whether it's mild, moderate, or severe. And this is important because not only does it determine the severity and the urgency, but it also guides the management. Diabetic foot osteomyelitis, DFO. DFO represents contiguous spread of infection to the bone and marks a major escalation in disease severity, with significantly increased risk of treatment failure, recurrence, as well as amputation. The diagnosis should be both systematic as well as evidence-based. The probe-to-bone test is a high-yield bedside tool, while MRI is the preferred diagnostic modality, as well as the gold standard remains bone biopsy. And this is critical for not only microbiological guidance, but also to ascertain definitive diagnosis and identify the culture. Management requires early detection and definitive and decisive intervention. DFO is associated with a higher risk of treatment failure and amputation, and typically necessitates prolonged antibiotics and/or surgical resection to achieve source control. This is where many patients cross a threshold. Osteomyelitis greatly increases the risk of both major and minor amputations and is difficult to eradicate without source control. Patients with DFO have a 5 times higher likelihood of overall amputations and a 3 times higher likelihood of a major amputation compared to just soft tissue infection alone. Antibiotics alone in this environment are often insufficient, particularly in the presence of ischemia. And incomplete treatment leads to not only recurrence, but progression as well as higher level, ultimately, of amputations. Infection drives 3 points: tissue destruction, systemic illness, and the need for surgical intervention. Delays allow the infection to advance faster than we actually intervene. What matters most is not what we do, but when we actually do it. Key intervals that we would look at would be admission to consults, as well as admission to surgical intervention. Every delay allows the infection to deepen and spread. And remember, time is tissue. For soft tissue infections, yes, antibiotics are important. But antibiotics alone without source control is incomplete therapy. Debridement, the removal of infected and/or necrotic tissue, is vital and essential to control. Management of DFO, diabetic foot osteomyelitis, comes down to one principle: source control first. Medical therapy is ideal and only works in carefully selected patients. These are those with limited bone involvement, no necrosis, no abscess, as well as being well perfused. But if there's necrosis, abscess, exposed bone, or a poor response to antibiotics, that's surgical. Antibiotics alone will not be enough. And remember, The duration of the antibiotic therapy is dependent on the surgical resection of bone. If we have clear margins with complete resection, that's shortened down to 2 to 3 weeks. However, if there's still infected bone or the margins aren't clear, usually that buys the patient at least 6 weeks of culture-directed antibiotics. The bottom line, identify these surgical patients early and control the source to prevent amputation. When we look closely at amputations, it's rarely due to just a single factor. They result from delayed recognition, missed osteomyelitis, poor perfusion, and we often attribute the outcomes to either patient severity or patient factors, but in many cases, it comes down and reflects a breakdown in 3 areas: coordination, timing, as well as access to care. In that sense, amputations are often the system's failure. The solution to the problem is not a single intervention, however. It's a system. The evaluation, diagnosis, and management of lower extremity wounds by primary care physicians, podiatrists, vascular surgeons, and wound care specialists is essential. Multidisciplinary care, including vascular surgery, infectious disease, as well as podiatry, working together in a coordinated, timely fashion significantly increases the chances of successfully healing an ulcer, subsequently preventing wound recurrence, as well as amputation. The goal is simple: the right expertise employed at the right time. The necessity of a multidisciplinary approach to limb preservation has been extensively studied and supported by the research. Implementation of a multidisciplinary limb preservation program can drastically reduce amputation rates by addressing complications earlier through coordinated care. Faster time to source control, eliminating delays and fragmented care, optimizing targeted antibiotic use, as well as standardized protocol-driven care. Programs who have integrated vascular surgeons, podiatrists, wound care specialists, endocrinologists, as well as physical therapists have reduced lower extremity amputation rates by 60 to 85% in various healthcare settings. So to summarize, DFI and DFO are the primary drivers of amputation. Osteomyelitis is a critical inflection point. Timing is the most modifiable factor, and multidisciplinary systems are essential to improving outcomes. We don't lose limbs from a lack of treatment, we lose them from delay. Act early, treat infection like a surgical emergency. Thank you.
All right, good afternoon. My name is Dr. Darrice Collins. I'm one of the podiatrists here with Northeast Georgia Physicians Group. And I've been tasked to tell you all what we're looking for from a podiatry standpoint when it comes to limb salvage and limb preservation. Quickly, how many residents do we have in here today? Okay, good, awesome. So we'll get to have a nice little talk. So I have no financial disclosures or interest in this talk other than making patients better, okay, and trying to save some limbs. So this is my team. This is our team, the podiatry team that you have, especially here at the Gainesville Hospital. You have Dr. Tyler Holabar, Dr. Charles Peebles, Dr. Randall Hansen, and myself. We'll be your primary consults for podiatry. We're the surgical service here for any foot and ankle infection needs that you may have here. So when a patient comes to the emergency department or gets admitted to the hospital for any foot infection, not necessarily a diabetic foot infection, but it could be from critical limb ischemia or idiopathic neuropathy, our laboratory workup is super essential. So with the residents out there, who's ordering ESRs? So none of our residents are ordering ESRs when we're working up any of our foot infections. So from a podiatry standpoint, our ESR is super important. The reason it's super important is that some of those wounds that we see that do not look acutely infected, they may have some underlying osteomyelitis. The literature says that around 70 millimeters per hour is highly suggestive of the osteomyelitis, but anecdotally, we also see osteomyelitis around 60. So we really like to see the ESR. A lot of times, the patient's already been here a couple of days, so we won't order it. And we kind of just use the advanced imaging. But an ESR is super essential to our early evaluation if there's underlying osteomyelitis. Who's ordering CRP? So no residents are ordering CRP either? Are we ordering anything? All right, so CRP is super important as well. The reason CRP is important is because how do we track our infection? You don't need to get the CRP every day. I usually order it every other day, but especially if we're leaving something open and doing a staged approach, we want to make sure that before we take the patient back to the operating room, that we have at least a downward trend in that inflammatory marker. We also have our hemoglobin A1C and our procalcitonin. Procalcitonin is a little bit of a newer kid on the block, and it helps us differentiate the bacterial sepsis from the local soft tissue inflammation. Obviously, you want to check the patient's kidneys to make sure that the antibiotics that you're giving them are appropriate. Personally, I would like to avoid any acute kidney injury. So, vancomycin may not always be appropriate for the patient as a broad spectrum. And then if you're not comfortable making that decision, that's where we get our infectious disease colleagues involved. The prealbumin and the albumin workup also is important to allow us to evaluate the patient's ability to heal. Our diagnostic imaging strategies. All right, residents, I need some participation. Patient comes to the emergency department, you think they have osteomyelitis. What is the first imaging that you're getting after your x-rays if you think that there's osteomyelitis? MRI, okay. Is anyone ordering a CT scan? Okay. So for us, CT scans have no real diagnostic utility for diabetic or any foot infection. The reason being is because on the right, you see an MRI. A CT scan will suggest osteomyelitis, but it's not sensitive to bone marrow changes, and it doesn't allow us to localize that infection and actually resect proximal to it. So when we go in and we amputate or do some bone resection, we usually map it. On the right here, you can see that the fifth metatarsal has increased bone marrow density. And so we would try to make sure that our resection is proximal to that and send some bone margins. Without the MRI, we're kind of blindly resecting. And just keep in mind, if you're kind of having a difficulty remembering that, is a CT scan is just a fancy X-ray. And X-rays give limited value, so CT scans also give limited value. If a patient can't get an MRI because they have a pacemaker or a spinal cord stimulator or some other issue that prohibits them from getting it, SPECT CTs and white blood cell label scans are great. You can pair that with a triphasic bone scan and order an Indian 111 or Indian 112 scan that can give some useful information about if there's any bone infection as well. Ultrasounds are good. I like ultrasounds if there's kind of a debate upon if that's a drainable abscess on MRI. Sometimes patients have MRI show a fluid collection, and that fluid collection may not be clinically significant. So sometimes I'll have an ultrasound come by and see if there's any abscess there. And if there is, then that's an indication for surgical incision and drainage, or even a percutaneous incision and drainage by interventional radiology. And that kind of helps us along that process with the decision tree. Our vascular evaluation. At this point, for us, for our podiatrists, we are leaning heavily on our arterial duplex Dopplers. Our vascular surgery team loves them. We love them as well. It allows us to actually locate where this patient may have a lesion or a stenosis that is contributing to their poor healing wound. The angiosome concept is how we typically decide what we request from vascular surgery, and vascular surgery uses it as well. So there's 3 arteries, as you know, that runs off to the lower extremity. You have your anterior tibial artery, your dorsalis pedis, your peroneal artery, which is on the outside part of the foot and ankle, and then your posterior tibial, which is inside. So if a patient has a lateral malleolus wound, but we get a lesion, or we have an angiogram that restores flow to the posterior tibial artery, that may not be that useful for us. So that's why this arterial Doppler is super important, because it allows us to use the angiosome concept to provide direct blood flow to the wound that we are having trouble healing at that time. So for podiatry, we're here for you in an inpatient setting and an outpatient setting. Our inpatient service is strictly surgical. Our primary focus is infection control and limb salvage. We're there to perform emergent incision and drainage procedures, clear deep space abscesses, do selective toe amputations, and even perform partial foot amputations as necessary. For the primary care physicians or in your outpatient clinics as well, we have outpatient surgical podiatry. That's where we perform a vast majority of our biomechanical offloading procedures. A lot of these wounds, when they're on the bottom of the foot, the vast majority of them are from some pressure point, whether a patient has a hammer toe that's causing an ulcer at the tip of the toe from walking, or whether it's a wound on the ball of the foot from a metatarsal that may be abnormally aligned. A lot of our procedures are minimally invasive in nature, and we actually encourage immediate weight bearing. And that's kind of our way of assisting our wound care team in surgically offloading these procedures, these wounds, when they are unsuccessful in doing conservative, traditional, total contact casts, et cetera. Our outpatient wound care center is our first line of defense. That's what they're specialized in. That's the cool part about being here and practicing in a system like ours, is that we have everything that we need for limb salvage. We just have to put it all together and make sure we execute it the right way. We have a wound care center, we have infectious disease, we have podiatry, and we have a great vascular surgery team. So with all that, and we also have endocrinology as well. So with all that, we have everything that we need to have a successful program and to be a really good bright spot. So the best clinical pearls that I can give you is that when a patient presents to the hospital and they have a wound on the bottom of the foot, the weight-bearing status should immediately be non-weight-bearing. That prevents any further tissue damage, any further tissue necrosis. The repetitive trauma accelerates, and I'm sure we've all seen that the wound looks a little bit worse from what it did with the mission. So strict non-weight bearing for the plantar wounds would be great. It's essential. Superficial swabs have no role because our skin has bacteria on it. So we're going to get some Staph epi, maybe even a little bit of Staph aureus. So if you want, you can just wait and allow us to get our deep cultures, our deep tissue, our deep swab cultures intraoperatively in a sterile environment that help narrow down that IV antibiotic choice. Probe the bone test is very useful. If you can see the bone, if you can touch the bone, there is a 89 to 90% chance that that bone is infected. All right. That also helps guide if you're going to get an MRI. So, you see the bone, you can touch it. You're like, oh, I don't need an MRI. But for the surgeons, the podiatrists, we need to know where to cut. So we want to come proximal to it. We don't want to leave any infection behind. And if we do, we want to make sure that we get some margins for our infectious disease so that it can treat appropriately with a short course of IV antibiotics postoperatively. So probe the bone is super useful. Keep your cotton tip applicators in your pocket. Again, arterial duplex Dopplers are what we really like, so we can get our vascular surgery team involved first. A lot of times we would like to wait until they optimize the patient. If it's acutely infected and we think that tissue necrosis is going to progress, we'll go in and we'll do a stage procedure. So we'll do a partial foot amputation and allow it to demarcate and wait for our vascular surgery colleagues to finish before we provide any closure to the area. Our NGPG limb salvage initiatives. So right now that we would love to have a standardized order set implemented, and we're working on that. Kind of takes the art out of medicine, and that's the cool part about limb salvage, is that there are no real right answers, but we have some things that we would like to see. But it allows you to practice the way you want and to kind of put your own twist on how you work up patients. With that, we will allow us to rapidly consult podiatry and vascular surgery. Our outpatient clinics are very full at this time, both wound care and podiatry. We're working on that on our end, but in an ideal world, we would love to see these patients seen within 48 to 72 hours for a wound in the wound care clinic, or within 48 to 72 hours in the podiatry clinic for critical limb ischemia. And then introduction to orthoplastics. So a lot of things that we talk about is infection control. There's other things that we can do before the wound gets infected. We can rotate muscles, we can rotate fasciocutaneous adipose tissue to cover these wounds, and we can sometimes even put on offloading fixators that can offload the plantar wound to allow the patient to weight bear as that wound heals. That's high level, and that's being done all over the place, and we have the opportunity to do that here as well. So the summary and key takeaways: MRI is king. Please order your MRIs. CT scan, unfortunately, provides no useful information for us and is not providing a good financial benefit for the patient as well. Arterial Dopplers are greater than ABIs. And then we also like to implement the toe and flow approach as well. Something like this where we can have ground rounds in an ideal world would be great to have it weekly. The literature has shown that it can reduce amputations by as minimum as 36%, but up to 82%. And just everyone knowing and being on the same page and early intervention being key. And like I said, orthoplastics is a really big thing. We can implement that here. My team has good training in that, and we can provide those procedures. But we need to have the patients educated, the hospitalists educated, the primary cares. It needs to be an education across the whole board because those are the last-ditch efforts to keep limbs on patients.
Hey everyone, I'm Bill Zickler. I'm one of the vascular surgeons here at NGPG. No relevant disclosures to what I'm talking about. So peripheral arterial disease. Risk factors for PAD are diabetes, hypertension, hyperlipidemia, CKD, end-stage renal disease, a current or former smoking history, and folks who have known atherosclerotic disease in another arterial bed. Could be coronary artery disease, ESRD, so renal arteries or carotids as well. On the right, I've got a little diagram which kind of goes through PAD. First, we have asymptomatic PAD. That's about 20 to 60% of patients who have peripheral arterial disease, and they report no symptoms at all. Some just don't walk far enough to be a claudicant, or they have another functional impairment, which could be orthopedic or spine in nature. Next is chronic symptomatic. These are our claudicants. Folks who have cramping or aching with exertion. That could either be the buttocks, thigh, or calves. And we only intervene on these folks if they have lifestyle limiting or debilitating claudication. And that's because folks who are claudicants, yeah, you can make them better, but at the same time, you can also flip them into acute limb ischemia or chronic limb-threatening ischemia. So for asymptomatic and chronic symptomatic folks, lifestyle modification is key. That's aspirin, statins, a supervised walking program, quitting smoking. Next is acute limb-threatening ischemia, or ALI. This is a more urgent or emergent vascular surgery issue. It requires revascularization usually quickly to regain function of their limb and prevent limb loss. ALI is pain, pallor, pulselessness, poikilothermia, paresthesias, or paralysis of their limb. Causes of this could be embolization, in situ thrombosis of the vessel, thrombosis of a pre-existing stent that was placed, an aneurysm, or trauma. The 3 levels of acute limb ischemia is Rutherford criteria. That's 1, 2, and 3. Rutherford 1, folks are motor sensory intact. This is usually an urgent issue. You can schedule them as an outpatient or just manage it prior to discharge. Rutherford 2A, this is an urgent intervention, usually within 24 hours. Folks can have some sensory issues of their limb. They have no arterial signals. They have venous signals, but their motor's intact. 2B is when you start having motor disturbances. This is a vascular emergency. Usually take them to the OR whenever you hear about it. And then Rutherford 3 is paralysis, no arterial or venous signals. This limb is non-salvageable and requires an amputation. And then for this talk is chronic limb-threatening ischemia, CLTI. This is estimated to be about 20% of patients with PAD. Folks have symptoms usually for greater than 2 weeks. It can include rest pain, non-healing wounds or ulcerations, or gangrene. And it's responsible for a majority of major and minor amputations related to PAD. Historical mortality is between 25 and 30% of patients, which is kind of crazy when you think about these folks with foot wounds. 25 to 30% would be dead in a year. 1 year major amputation rate is 30%. And with rapid revascularization, they have decreased morbidity and mortality. Major limb loss, that's below knee amputations and above knee amputations. 1 year mortality with a BKA is 25% in this patient population. Above knee amputation can be as high as 40%. So workup. Dr. Collins already talked about this a bit. Pulse exam. So femoral pulse exam, popliteal, and pedal pulse exam. Femoral pulse exam is important because that can determine the next study that's ordered. We love arterial duplexes on everybody, kind of like podiatry. The caveat, non-compressible vessels for an ABI isn't very accurate, just because they could have calcified disease that's not really seen on the duplex. So I think anybody that has a non-palpable pedal pulses and a foot wound, they deserve angiography. And then if folks have a non-palpable femoral pulse, best imaging study for us would be a CTA, abdomen and pelvis with runoff. It's quick and it gives you a lot of information on how to revascularize. So for revascularization, there's open, hybrid procedures, and endovascular. And hybrid combines both open and endovascular intervention in the same operative period. So I have an example. This is a patient that we took care of probably about a year ago now. He was a vascular patient. ID saw him for prolonged antibiotics. He saw wound care as an outpatient for forever. And then Dr. Collins, your team took care of his toes. He's a 66-year-old male with a history of diabetes, coronary artery disease, and smoking history. He presented with a non-healing right second toe and heel wound for several weeks. The ER ordered a CTA, which showed a 50% right iliac and common femoral stenosis, and included SFA with reconstitution of the above knee popliteal, near occlusive TP trunk and proximal PT stenosis, occluded AT, so his real and only runoff to his foot was PT. So in May 2025, we took him to the EVOR. We performed a hybrid revascularization. We did a right iliofemoral endarterectomy, retrograde iliac stenting, recanalization of his SFA with stenting, and TP trunk and PT angioplasty. You can see on the image on the left, he has an external iliac stenosis. It was probably 50 to 75%. In the middle picture, you can see his occluded SFA. And then on the right, you can see his near occlusive TP trunk stenosis proximally, and then his PT disease. Completion imaging, you can see his external iliac stenosis is completely resolved. He has inline flow through his SFA, which looks good. His TP trunk looks much better, and he's got PT runoff to his foot with AT reconstitution at his ankle. Of course, nothing we do lasts forever. So in July 2025, he had a worsening toe wound. He refused amputation. In July, he was noted to have a popliteal stent occlusion. We were unable to recanalize endovascular, so he underwent a right femoral to posterior tibial in situ great saphenous vein bypass. In September 2025, after several months, he finally agreed to an amputation, which he healed in about a month. On surveillance arterial duplex, he was noted to have concern for stenosis of his bypass, which wasn't the case. His bypass looked great, but he underwent angiography, and we performed SFA angioplasty. You can see there's his proximal SFA, his jump graft coming off the mid SFA there, going down to the PT on the middle picture, and then his PT runoff to the foot. Thank you.
My name is Meghan Hill. I'm a nurse practitioner over at Wound Care, and it's a real pleasure to be here. I have no financial disclosures. I'll be talking about limb preservation, what we're currently doing here at NGHS, what some of the studies show on healing diabetic foot ulcers, and how early prevention prevents limb loss, which we've already learned a lot about today. Our Limb Preservation Committee, we meet every Thursday, the last Thursday of the month, real early in the morning. And we're currently working on data collection with OpEx team and with EPIC, trying to get some reports that we can see how many amputations we are doing, where exactly we are, so we can know how to improve and if we are improving, right? We work with both ambulatory and non-ambulatory groups, and we're happy to do it. Here's our charter. So we're looking through all of the processes at NGHS that touch a diabetic foot ulcer and trying to improve them, all with the goal to prevent lower extremity amputations. So we think about, and we see often this left side of my slide, that the clinical states for diabetic foot ulcers, basically they've got diabetes and it just progresses, right? DFU, they get a wound, and then the limb loss is the state before, right? But I kind of talk to my patients about being on more of a roller coaster of clinical states, where we might get a diabetic foot ulcer and then proceed to healing, and then we go back down and back up, always with the mindset of their quality of life going up, right, when they have a healed ulcer, and then their cost and quality of life going down when they have an active ulcer. So that's why this is so important. The more education that patients have, studies show, the more that they'll end up on this healed side, and the more that they have worsening diabetes, neuropathy, foot deformities, PAD, and end-stage renal disease, the more they end on this other side of the slide here. So early intervention, is really important to prevent the foot infection, to get that DFU going more towards those positive education, positive clinical states. Offload that foot, get them debridements, get them revascularized so that they have a more positive outcome. I'll show you these 2 feet that we had the pleasure of working on. Who remembers the phases of wound healing? Anybody? Hemostasis, inflammation, proliferation, and remodeling. So where are these feet? Where are both of these feet? Which stage of wound healing are they? Inflammation. Right, so these feet are very similar in every way possible. They're in the same stage of wound healing. They're very similar patients. PVD, gait instability. They had both of them had a very good support network, which is not something you always see, but they had a wonderful support network, very willing to return to the clinic. So where do the studies tell us? Like, this is the most common question I probably get on Epic Chat is, what do I put on their wound? Right, what do I need to put on this diabetic foot wound? And the vast majority of the studies are on tissue substitutes. And these percentages, it says 86%. Keep in mind, this is 86% were closed with adequate debridement, standard of care, tissue substitutes in 12 weeks. So this is not a fast process, even with some of the absolute best wound care that you can get them. The wound has to be ready for any sort of tissue substitute, so they have to be clean, no necrosis, no infection. So that can be a tall order for some of the foot ulcers that we see. And there's a lot of barriers to tissue substitutes. They can be very expensive, so our folks who might not have insurance might have a difficult time getting them. And just knowledge about how to apply them and what your options are, inpatient versus outpatient. Surgical options, right? I have so many patients who come in and say, I've had this ulcer on the bottom of my foot for 4 years, and you're just, 4 years, that's incredible. But it happens, and it happens a lot. So I try to talk to them a lot about our options that we can offer them here at NGHS. These are can be done together, they can be done separately. If you do notice a patient with a plantar ulcer that you think could benefit from any of these procedures, make sure that their A1C is well controlled, because these are all elective procedures. So they have to have a well-controlled A1C. If it's above 10, these procedures won't heal, right? So here's the outcome for these 2 feet. This patient ended up with a foot infection, ended up with a great toe amputation. So now they have even greater foot deformity. The other patient ended up with a tissue substitute, really good debridement, and gastric soleus recession. So that patient's offloading, surgical offloading began to heal that ulcer. I think the actual gastric soleus recession incision healed after the foot did, because they had so much swelling and edema from their PVD that we had to control for that. It actually took longer for that than it actually did the foot ulcer to heal. So this patient to this day has healed, and this patient is more on the roller coaster, right, with that increased deformity. So just some final tips, takeaways. Insurance can take 30 days of standard of care before they'll agree to any of these interventions anyway. So make sure that when you note a diabetic foot ulcer, that you're noting it, that it's not just open wound of foot, that it's diabetic foot ulcer of the toe to whatever layer, muscle, bone, wherever you're at. Make sure that you have a good, thorough assessment. That's really important for a diabetic foot ulcer, so we can see where we are, so we can see where we're going. They do need frequent visits, so refer them very quickly to wound care. These ulcers can develop osteomyelitis as soon as weeks, sometimes less. And when they often have already had that ulcer for several weeks, it's important to get them in early. And then, of course, outpatient services, make sure they're seeing an orthotist. If they have diabetes, they need diabetic insoles. They need to be doing their daily foot checks. Here are my references, and this is my name, my number. If you ever need me to get a hold of me or have any questions, please feel free to reach out. Thank you.
I'm Dr. Supriya Mannepalli, Assistant Medical Director for Infection Prevention and Control, Antimicrobial Stewardship. First, I would like to thank all the speakers for agreeing to be part of this multidisciplinary presentation. The way I look at limb preservation is two. One is the long-term management, patients who have chronic ulcers, modifiable risk factors, addressing those and preventing the progression, preventing limb loss. Other is recognition of invasive severe necrotizing infections in a timely manner. And Dr. McCulloch alluded to that, where for those patients presenting with this acute necrotizing infection, 0 to 2 hours is what you had in your slide, Dr. McCulloch, for evaluation, initial evaluation. And as I was reviewing information for this talk, one of the things that really, I think we all know it, but I think it's important, it's a good reminder, is that necrotizing fasciitis, these necrotizing infections, are clinical diagnosis. We should not be relying on imaging. And there was one study I looked at where almost 45 to 70% of the patients had no gas or any specific findings on their imaging, and it was mainly a clinical diagnosis. And this is a case, actually, we had a recent case, and I see Dr. Varghese here in the audience, and if she wants to add, I would like for her to add, where the patient presented initially where the foot looked, there was some redness, there was severe pain, swelling, and then it progressed to what it looks like with that purplish discoloration. And the patient, vascular surgery, podiatry were all consulted, but patient did require amputation. Dr. Varghese, anything you want to add?
Thank you. I was consulted on this patient, not necessarily, I believe, for the cellulitis. I think he had bacteremia. By the time I had seen the patient, comparing the images of when he presented, which is on the left, to when I saw him, I think it was 2 days later, he had progression of the rash, he had progression of swelling. He also had pain out of proportion to what it looked like as well. So certainly was concerned about a more invasive infection and not just the run-of-the-mill cellulitis, because he was on appropriate antimicrobial therapy. He was actually on broad-spectrum antimicrobial therapy. So when you see somebody who has cellulitis that's actually rapidly progressing despite being on appropriate antimicrobial therapy, that definitely is a red flag and should raise some suspicion for a more serious infectious process.
Thank you for sharing that. And for these type of infections, it is the most important thing is source control, timely intervention, and not antibiotics. And what I really want to highlight, putting the information that's been presented by our different specialists together, I'm going to refer to this particular publication where they actually created what they call as a hot foot line in the ED. And if you refer to the IDSA guidelines, they recommend urgent surgical intervention for patients presenting with extensive gangrene, necrotizing infections, signs suggestive of deep-seated infection like that patient, compartment syndrome, or severe lower limb ischemia. And again, a reminder that necrotizing infections, they are clinical surgical diagnosis and require emergency surgical exploration. And per guidelines, but actually I'm going to now start referring to what Dr. McCulloch presented, the guidelines recommend early intervention within 24 to 48 hours for patients with moderate to severe DFIs and to remove the infected and necrotic tissues. And it's very important to consult the appropriate surgical specialties with podiatry, vascular surgery, and to ensure that they get that surgical intervention timely. And in this particular publication where I was referring to, the emergency department had just one point of contact based on if the patient is presenting with a traumatic lower extremity wound, whether presenting to the ER or something changes on the inpatient ward, then the hot foot line was activated, similar to stroke or STEMI. And there was just one point of contact. If it was infection dominant presentation, podiatry was the primary contact. And they would involve the others, whether it's vascular surgery, infectious diseases, anyone else needed, endocrinology. And if ischemia was the dominant presentation, then vascular surgery was the primary point of contact. So the ED had to just contact one specialist, and then the rest of it flowed through this multidisciplinary team and coordination. And hot foot line was activated for any traumatic tissue loss below the knee, signs of severe foot infection, or ischemia or vascular compromise. I'm really hoping that we are able to do something like that here, where the patients that are presenting to the ED or changes in the inpatient ward, we have something similar where we can get the appropriate consultants involved early and they receive appropriate surgical intervention timely. And a few of these have already been covered, but I'm going to just highlight. Don't treat uninfected ulcers with antibiotics. For mild infections, there's no urgency in starting antibiotics. Get the right cultures. Don't swab the wound superficially. Even if you're getting a bedside culture, do that after the debridement. And with the whenever patient goes for surgery, podiatry intervention, we always request for the margins. We worked with our lab here to make sure that we get the margin pathology earlier than the rest of the bone so that we can actually facilitate throughput through that. So getting the bone cultures, deep cultures is very important to guide therapy. One of the initiatives as part of this, what we're working on with Dr. Austin and the team is DFI order sets. And for that, we recently approved our antibiotic guidance for both inpatient and outpatient for DFI. And again, I think one thing I want to make make a case here is we don't need anti-MRSA and anti-Pseudomonas coverage for all diabetic foot infection patients. That's something we all do. Vancomycin or vancomycin flagyl. If you refer to the DFI guidelines published by IDSA, they have clear guidance when to add anti-MRSA or anti-Pseudomonal therapy. And for Pseudomonas, especially if it's been isolated in the past, if the patient is living in Asia or North Africa, or again, this is not something we commonly see, or any risk factors, again, where we're concerned about Pseudomonas as the pathogen. And I'm not going to read through all of this, but I just wanted to share, we're hoping that this will be added to the antibiotic guidance in the EPIC under the sidebar summary section. So these are the antibiotics that we recently approved for mild infections. As you see here, there's an oral route. We don't need to give IV antibiotics just because the patient is here for something else and we happen to see they have an ulcer on the foot. They don't need IV antibiotics and they don't necessarily need MRSA coverage all the time. And for moderate infections here, again, moderate, no complicating factors. First line is Amsulbactam. And then if we cannot give Amsulbactam, then ceftriaxone with metronidazole if there is ischemia, second line ertapenem, and then if history of MRSA infection or colonization, that's when we recommend adding anti-MRSA agents, and then if any recent history of Pseudomonas, adding that Pseudomonas coverage. And for severe infections, one point I want to highlight is use of the antitoxin agents if you're concerned about necrotizing infections. So we have been using more linezolid over clindamycin recently, and that is supported by evidence. So it's very important that if you're suspecting necrotizing infections, you do add that antitoxin agent to your other broad spectrum antibiotic coverage. Here, we do recommend covering for MRSA and Pseudomonas until we have further information if the patient has severe necrotizing infection. But otherwise, again, anti-pseudomonal coverage is not recommended for all of these patients. And if you look at diabetic foot infections, I think it's less than 10% are caused by Pseudomonas. And again, duration, I hope by this time ID is involved and we're able to guide you with the duration of the antibiotics. And if we refer to the new, they're 3 years old already, but if the patient has resection and the margins are clear, we only need 2 to 5 days of antibiotics. And if the margins are positive, in the past we used to do the full 6 weeks, but minimum 3 weeks, and then follow the clinical course and adjust as needed. And not every patient, I look at osteomyelitis as a surgical problem. I think it's extremely important to get our consultants involved, get their source control, and antibiotics I see as second line for these patients with osteomyelitis. That's all I have, and I think we have 4 minutes for questions. Thank you for attending today.
Okay, if anybody has a question, please raise your hand. I'll bring you the microphone.
Well, I'll just end and thank you for the invitation and the opportunity to talk about limb preservation. Anyone who knows me knows that if you get in front of me, the first thing I'm usually talking about is limb preservation. I've been talking about that since I got here in 2022. It's a higher overarching goal that we have for the Wound Management Center, and getting our colleagues from vascular surgery, podiatry, infectious disease, hospital medicine, endocrinology, PT, as well as everything else. It is really, truly inspiring to see this come to fruition, start to generate. It's much bigger than ourselves. It's what we can do to improve the health of our community, which we all know is heavily diabetic. So thank you for your attention today, and I'll yield.
The cultures I see the most from limbs are positive for MRSA. What are each of your thoughts on implementing decolonization for surgical patients?
Again, the most important thing when we're obtaining cultures is that we're not superficially swabbing those wounds. Because if so, we'll pick up a bunch of skin bacteria, and Staph aureus can be a skin bacteria. We do recommend decolonization. It's also a requirement for certain elective surgeries here at our health system where patients are receiving any implants, especially our ortho knee replacements, hip replacements. Also for cardiac, where any prosthetic valves will be placed, or spinal surgeries where hardware would be placed, we recommend and require decolonization. Either they can screen and see if they are a carrier for MRSA or Staph aureus and then decolonize, or they can just go ahead and decolonize. Screening would be good because if they actually test positive for MRSA, we recommend adding vancomycin to cefazolin pre-op. Dr. Ross also adds a good point, actually, because decolonization is not like a cure for ever. The only reason we do decolonization pre-op is for the short-term benefit. While they have the surgery and they're recovering for it, they don't get infection. But it's very easy to get recolonized even if you do the decolonization. So I think the most important thing, do not get superficial swabs. Decolonization only for certain scenarios. And hand hygiene is the most important thing.
Thank you so much. Thank you, everybody. That's it for today. Have a great rest of the day.